Drugs that act on the renin, angiotensin, aldosterone system are extremely important in both cardiac and diabetic patients. Before we talk about the classes, I want to do an overview of the RAAS system itself, because if you can memorize this picture, you know all the drugs and their effects of the RAAS system. Now we start with angiotensinogen in the blood. It is converted by renin into angiotensin 1, which is in an inactive form. Now they've made it super easy for us. The angiotensin converting enzyme will take angiotensin 1 to angiotensin 2. From there are multiple effects on the system, including a decrease in sympathetic nervous system output, an increase in vasodilation of the vessels, and a decrease in the retention of sodium and water. All of these will cause a decrease in blood pressure and improve the workload of the heart. Now you can see here where each class of drugs is going to have the effect. I want you to remember that the earlier on that they affect, the more side effects they have downstream. Renin inhibitors are going to have the most, followed by ACE, then ARB. And we'll talk about these one at a time, but this picture is super crucial. Starting with the most important set of drugs in this class, ACE inhibitors, angiotensin converting enzyme inhibitors. These are drugs that end in pril, and although captopril is considered the prototype, lisinopril and enalapril are probably the most commonly used in clinic. Now these are going to block the conversion once again of angiotensin 1 to angiotensin 2, but they have the additional side effect of blocking the metabolism of bradykinin, which will increase the level of bradykinin. Now, this is super important because the number one reason that somebody stops using an ACE inhibitor is because of the cough that is caused by bradykinin. If anybody shows up to your clinic, regardless of if they look sick, if they report just a cough that's only been there for a few minutes, it doesn't even bug them, you're going to look and see if they have an ACE inhibitor on board. Now, the mechanism of action comes from both effects, including reducing angiotensin 2, dilating blood vessels, and reducing blood volume, and bradykinin will cause vasodilation. This is the only drug with a bradykinin effect. I want you to use these in 3 different sets of patients. The first is hypertension. The second is heart failure. All patients with heart failure should be on an ACE inhibitor. And the third is kidney protection in both diabetic and non-diabetic patients. So, high blood pressure, heart failure, and kidney protection, but most important in those diabetic patients. There are some additional effects that are beneficial, but these are the most important. Now, it looks like there's a lot of side effects here, but I just wanted to take time to explain these because there's only a few, but they're very important. Hypotension, which can occur with any of these blood pressure lowering drugs, especially when used in combination. High potassium, which we know that if aldosterone is blocked from our diuretics video, that it's going to cause potassium to be held on. This can be beneficial if you're using it with a diuretic that offloads potassium, but if you're using too many potassium-sparing agents, it will cause some problems. Renal failure, I won't really get into because I just told you that it's kidney protective, but most common renal failure happens in individuals with severely damaged kidneys already. That's bilateral renal artery stenosis or a single kidney with stenotic vessels, and it's pretty rare in terms of the patient population that it'll occur in. But these 2 effects of bradykinin are probably the most important. So the first is that cough. Now this is the number one reason, once again, that somebody fails an ACE inhibitor. As a result, they'll be placed on an ARB or something else in these categories. The second is angioedema. Now, this can be fatal. It's going to risk blocking off the airway, either through swelling of the airway, swelling of the lips, swelling of the tongue. And the interesting thing about this is that it can happen at any time while taking the drug. So you may have a patient who's been on it for 3-4 years, and all of a sudden they have a reaction. This is possible, even though most drugs initially will present with that allergic reaction or angioedema. For interactions, once again, blood pressure lowering, potassium increasing agents will both affect here. Bilateral renal artery stenosis, which we've already covered, and if they've had a previous reaction of angioedema, we don't test the drug again on them. The black box warning here is for individuals that are pregnant and even to some extent women of reproductive age that may become pregnant because there are so many different effects that can occur in pregnancy. These are usually combined with a beta blocker and a diuretic for that symptomatic relief of heart failure. But I want you to remember this that's in bold. ACE inhibitors are the only drug in the RAAS system that are approved to reduce mortality in cardiovascular events. None of the other drugs are, only ACE inhibitors, and that's why we need to put all of our heart failure patients on this drug. We also want our hypertension patients on this drug because in the future, they're likely to develop heart problems as well. If an individual fails an ACE inhibitor for whatever reason, we can place them on an ARB or an angiotensin II receptor blocker. These are drugs that end in sartan. You'll most commonly see losartan, olmesartan, and valsartan. They have many of the same effects as the ACE inhibitors, except for that they don't block bradykinin metabolism. So that means that you aren't going to see the cough that is the most common reason for failing the ACE inhibitors. These are second line to ACE inhibitors because, once again, they do not or have not been proven to reduce the risk of cardiovascular mortality. We're still going to use them in the same set of patients: hypertension, heart failure, and kidney protection for diabetics. The side effects are minimal, including that angioedema, but it's a much lower rate because of the bradykinin being intact, and same interactions and contraindications, including pregnancy. The important PK/PD to remember here is that losartan is the only prodrug, meaning that it must be converted in the body to an active form. Now, direct renin inhibitors aren't really used in clinic. I have not yet seen one used in cardiopulmonary family medicine. However, there's two important things I want you to remember about these. They are only approved for hypertension. They are not used for heart failure. And number two, that these act really early in the RAAS system, so they're going to have the most side effects. They're going to have all the same side effects as ACE inhibitors, with dose-dependent diarrhea, abdominal pain, hyperkalemia. So these aren't really used very commonly. They also have CYP interactions, although they don't have any listed contraindications. Now, aldosterone antagonists, we talked a little bit about in our diuretics video. These are going to block the receptors for aldosterone, causing a decrease in the blood volume and lowering the blood pressure. These are used as add-on therapy most commonly for those with high blood pressure and heart failure, and they can actually improve mortality in heart failure as add-on therapy. The side effects for these are going to be some GI effects, but most important to remember is the endocrine effects because they're blocking the aldosterone. This is gynecomastia, menstrual irregularities, and they're higher in spironolactone than they are in eplerenone. However, I've most commonly seen spironolactone used because it doesn't have CYP interactions or these interesting side effects that occur in diabetic patients. Once again, there's a black box warning of tumor creation seen only in rats, and it's not something that individuals really worry about.